All right, welcome. We're going to tackle a super important high-yield topic for all you postgraduate residents out there, the organic mimics of depression. This is something that can trip up even the pros. Our goal here is to build a solid organic-first framework that you can use to confidently rule out medical causes. And trust me, this is a skill that's absolutely vital for your exams and, more importantly, for your patients. So let's start with the one question you have to ask yourself every single time a patient comes in with depressive symptoms. Is this really a primary psychiatric illness, or is it a medical condition wearing a very convincing disguise? Getting this right from the get-go is one of the most critical skills you will ever develop. And here's why it matters so much. Look, getting this wrong isn't just a small diagnostic oopsie. It could mean you're delaying treatment for a brain tumor, an autoimmune disease, you name it. It is a massive clinical pitfall, and you can absolutely bet that examiners love to test your ability to spot it. Okay, so where do we start? It all begins with a meticulous history. I want you to think of yourself as a detective. You're on the hunt, actively searching for any clue, any little detail that points away from a straightforward psychiatric diagnosis and towards an underlying organic cause. This slide is just key. It shows you the classic picture of depression versus the stuff that should make your alarm bells go off. You know, primary depression often creeps in slowly. Maybe there's a clear stressor, but an organic cause, that can hit hyperacutely, like boom, out of nowhere. It might also show up with a ton of physical complaints, sleeping all the time, and a really frustrating resistance to your standard antidepressants. So how do you find these atypical features? You gotta be systematic. This checklist right here is your guide. Ask yourself, are there constitutional symptoms, like a fever or weight loss they can't explain? Any new neurological issues, like headaches or, a seizure? And you absolutely have to review that medication list. A recent course of steroids, or even starting a simple beta blocker could be the smoking gun. Next up, the physical exam. This is where we go from listening to the story to finding the hard evidence. We're looking for objective proof to back up all those clues we just gathered from the history. When you're doing the exam, you need a really sharp eye. Look for those subtle neurological signs. Is that person just moving slow because they're depressed? Or is it true Parkinsonism? Is their walk a little off because of apathy? Or is that genuine ataxia? And please, don't forget the systemic signs. That malar rash screaming lupus, the hyperpigmentation of Addison's disease, or the classic dry skin of hypothyroidism, these are all pure high-yield clues. Okay, now let's zero in on the absolute must-knows for your exams, the red flags. These are the specific findings that should immediately make you stop, sound the alarm, and escalate your investigation way beyond standard psychiatric care. You're going to want to tattoo this list on your brain. If your patient shows up with their first ever depressive episode after the age of 50, that is a massive red flag. Same thing for a hyperacute onset. We're talking it came on in less than 72 hours. Or if they have major cognitive problems that are looking more like dementia. Any one of these should make you slam on the brakes and think, wait a minute, what am I missing here? And this right here is the bottom line. Please remember this for your exams, remember this for your practice. You don't need a whole laundry list of symptoms. The presence of even one of these red flags completely changes the game. Your management plan flips from treat depression to find the underlying medical cause. Okay, so you've spotted a red flag. Now what? You don't just order every test under the sun, right? No, you proceed with a smart, logical, cost-effective tiered approach. Your clinical findings are your guide. This lays out the path perfectly. Tier 1 is your basic screening for pretty much everyone with a new depressive episode, your CBC, CMP, TSH. But if you have those red flags, like a new onset seizure, you immediately escalate to Tier 2. That's when you start thinking about an MRI or an EEG. Tier 3 is for when you have a very specific suspicion, like ordering that autoimmune panel because you saw a malar rash and you're thinking lupus. Finally, we need a way to organize all this. You need a comprehensive differential diagnosis so you don't miss anything, especially when you're under the pressure of an exam. And that is where this master mnemonic comes in. To make sure you're thinking of everything, use VINDICATE as your mental filing cabinet. It is a safety net. It forces you to systematically run through every major category of disease, from vascular problems to endocrine disorders, so that nothing dangerous falls through the cracks. This table right here, this is your ultimate high-yield summary. It connects every letter of that mnemonic to the conditions you absolutely must know. V for vascular, immediately think post-stroke depression. I for iatrogenic should make you think of steroids. And E for endocrine, that's your classic hypothyroidism or Cushing's. This is your roadmap to building a bulletproof differential. So, the crucial takeaway from all this is simple. Always, always think organic first. If you use the structured approach, history, red flags, tiered investigations, and the VINDICATE framework, you are going to be prepared for any complex case they throw you. So I'll leave you with this to think about. The next time a patient presents with treatment-resistant depression, which letter of VINDICATE will you investigate first? And why?